Hi everyone. So today we are covering our renal pathology. So our kidneys are part of the urologic system or the urinary system, but today we're mainly just going to be talking about the kidneys themselves. The bladder pathology PowerPoint is pretty self-explanatory, pretty straightforward. So I'm going to have you guys do that on your own time. And if you have any questions about the information that's on that PowerPoint, you can absolutely reach out to me. But that one, it's pretty self-explanatory. Whereas renal, there are a lot of nuances between some of these different pathologies, tumors, and conditions. So we're going to spend a little bit more time on specifically the pathologies associated to the kidneys themselves. So like we said, today we're going to be talking about the upper urinary system, talking about the renals, the kidneys themselves. So let's talk about our anatomic variants first. If you were in my lab group last week, I apologize. One of the most common types of variants that we see in the kidney is a column of Bertin, and then we're also going to talk about on the next slide a dromedary hump. These are so common for us to see them on ultrasound, but it's very easy to mistake both of these variants for pathology or for some type of discrete mass that's happening in the kidney themselves. So a column of Bertin, this is when we have that renal cortex that actually starts to extend inward into the pelvis. So it can kind of mimic some type of mass in the sinus or the pelvis of the kidney. But really all it is this little extra extension, this little pocket of cortical tissue that's extending inward. On ultrasound, we are not going to see a change in that sinus fat composition. So that's a good sign. That's telling us that this isn't any type of mass that's disturbing the normal makeup of the kidney. But we are going to see that prominent cortical tissue extending inward into that sinus. And again, we can very easily mistake a column of Bertin for a renal mass or tumor. So this top picture here, we see our nice cortex interface, and then we see this guy hanging out. Kind of looks like a polyp a little bit, right? But all it is that prominent extension of the cortex into the inner part of that kidney. A little bit more prominent on that bottom picture. You may even be saying, well, how do we know that this isn't a mass, right? We wouldn't be able to differentiate that from the cortical tissue in two planes, right? So here we're in our SAG picture, and we can see that nice continuation with the cortex right here, right? So we don't see a border on the cortical aspect of this finding, right? We don't see a border there. It's just a nice extension of that cortical tissue inward. Next, we have our dromedary hump, so very similar to a column of Bertin, but instead of that cortex extending inward into the kidney, it is now extending outward, and it's causing that camelback type of hump, right? So we can see this bulging of the surface in both of these images. These are classic appearances of a dromedary hump. Again, very common for us to see this on ultrasound, and we don't want to confuse this for pathology. So this is when we have lateral cortical thickening or an extension of that cortical tissue outward from the kidney. It's typically going to be in that mid portion of the kidney, so we're not really going to see a dromedary hump in the upper pole or the lower pole, mainly going to be in the mid pole. Like, you're not going to see a dromedary hump right here. So classically in that mid pole. On ultrasound, it's going to display the same characteristics as normal cortical tissue. We're going to see normal vascularity to that tissue, normal echogenicity. We're going to see that bulge from that outer border of the cortex. And again, we can easily mistake this for some type of discrete mass, but we're looking for borders. When we're looking for pathology, you need to see defined borders in two planes in order to classify that as a focal finding. So that's why we don't want to get confused with a discrete mass and a normal variant with the kidneys in particular. Now, kidney pathology is really challenging. Kidneys are hard enough to image themselves. And if you do have a discrete mass or a small mass that's forming in the kidney, it takes a lot of time, a lot of experience, and a lot of patience to be able to find these things. So we don't want to just blow by the kidney just because we're seeing it well. We really want to take time to interpret how all of that tissue looks. We're looking at the sinus, we're looking at the cortex, we're looking at the borders, we're looking at the hilum, right? So there are a lot of things that we need to evaluate on the kidneys in order to say that they look normal. Another anatomic variant that we don't really see as commonly as the first two, but we do see a good bit of it, is a junctional parenchymal defect. Again, super normal. This is going to result from a disruption in the embryology phase of our kidneys. So basically, our kidneys kind of start as one glob of tissue in the pelvis. As we grow in utero, they start to separate and they move upward. As that's happening, the kidneys are super, super lobulated. They kind of look like a nerd, right? That nerd candy where there's all just lumps and bumps. They're not nice and smooth. And as we mature and as we get older, our kidneys start to smooth out. So when we have that normal fusion of those lumps and bumps in that embryologic kidney, that's what we want to see. We want to see that nice smooth border of our kidney because all of those lobules have fused together. Now, when those lobules don't fuse together and they kind of continue to stay lumpy bumpy, that's when we have this defect in that functional tissue because that functional tissue didn't fuse together. And that's why we can kind of see this little divot in that tissue of the kidney. So super normal. We wouldn't even really say anything of that in our report. So on ultrasound, we're going to see this triangular or this linear hyperechoic structure. That's just showing that separation between those two regions of the kidney that should be fused together. We usually are going to see this on the anterior superior or the posterior inferior aspect of the kidney. Next, we have persistent fetal lobulation. So this kind of is very closely related to that junctional parenchymal defect, where we said the kidney starts as one really lumpy, bumpy glob of tissue. As they separate and as they move up from our pelvis to our flanks, they still kind of have these lumps and bumps to them. And as all of those pieces of tissue start to fuse together, that's when we get that nice smooth kidney border. But again, if we don't have that fusion of those pieces, excuse me, those pieces of tissue, we're going to have these persistent fetal lobulations. So basically, this is when we see those lobules or those lumps and bumps in the tissue of the kidney past the age of 5. Again, benign, not really anything we're going to do about it. But again, we just don't want to confuse this for some type of pathology. And on ultrasound, we're going to very easily be able to identify those lumps in that fetal in that renal tissue and parenchyma. We're usually going to see this more so on the anterior surface of the kidney as well. And just to identify here, these are our fetal lobulations, whereas this part of the kidney is nice and smooth. Next, we have horseshoe kidney. So I have only seen a horseshoe kidney once, and it's a very, very interesting type of variant to scan. And it is exactly what it says in the name, right? It has the shape of a horseshoe. So this is going to be associated with improper ascent of those kidneys and malrotation. So as those kidneys are forming in our pelvis, we expect them to separate and move upward. If something happens in that process and it stops the kidneys from continuing to move up and away from each other, they're going to kind of get stuck in that lower region, and they're still going to be partially fused together. So this is the most common form of a fusion anomaly. Usually the lower poles of the kidneys are going to be fused together, and that's again because during embryology, they move up and they separate as they move up. So if we're moving up a little bit, we're going to separate a little bit, but then our bottom portions of those kidneys are still going to be in contact with each other because that ascent and separation has not happened properly. So the midline connection between the two kidneys is known as the isthmus, just like the thyroid. These patients are going to have a high association with kidney stones. On ultrasound, we are going to see this fused kidney lower in the pelvis than we obviously would see them in the flanks. We also, because of this low position and because of the shape that they take on with this malrotation and this fusion, they're going to look like a lymph node. So we can sometimes confuse this with lymphadenopathy in the pelvis. And usually when they are still in the pelvis, they're going to continue to be rotated anteriorly. So they're not going to have that midline rotation that we expect to see from the kidneys. They're still going to be facing kind of forward. As you can see by that top diagram, the hilums are turned towards us, towards that anterior aspect of the patient's pelvis. And then you can also see from that diagram as well that the kidneys are located and they're fused really well. This is going to be our IMA branching off of the aorta. These are our renal arteries. Those are our lumbar arteries. And then here we have a renal artery branching off. So the kidneys are going to be positioned a lot lower. You can also see that the isthmus is positioned right above the bifurcation of the aorta. So that's a lot lower and more anterior than we would expect to find normal kidneys that have moved all the way up and separated fully from each other. And then down here, we're looking in a transverse plane. We have our spine here, we have our aorta here, we have our isthmus here, and then here we have our transverse left kidney coming into our transverse right kidney. Okay, so we're still kind of continuing on with the variants here, but now we're talking about an abnormal number of kidneys. So renal agenesis is the total failure of a kidney to develop in utero. So we are a fetus, we have developed a kidney, that kidney has moved up on its own, but we only have one. This is more common in male babies than in female babies. A lot of renal pathology and conditions are more common in male babies and in male patients. If this is a bilateral condition, so if we have bilateral renal agenesis, that is incompatible with life. You cannot survive without any functional kidney tissue. So unfortunately, if those babies are diagnosed with bilateral renal agenesis in utero, we do not expect them to live to birth. Unilateral, of course, is more common. That's usually what we're seeing. And it has a normal prognosis. That one kidney just does the job of two. And sometimes that one kidney is going to be slightly larger than normal because it's taking on more work, right? Because it is doing the work of two kidneys. And then on ultrasound, we're obviously not going to see any renal tissue in that flank and in the pelvis. Again, we want to make sure that we are checking everywhere possible for a kidney to be positioned, even if it's not in the normal flank position. And then as we're doing our bladder pictures, of course, if we're missing our right kidney, we're not going to have a right jet light up, right? So that's kind of just a common sense connection there. Next, we have supernumerary kidney, and this is when we have an extra kidney. So these patients are rather lucky. This is the abnormal division that, again, is going to occur during embryology, and it's when we get the complete duplication of a kidney. It is going to have its own vascular supply, its own collecting system, so it has its own ureter that attaches to the bladder, and it's going to have functional tissue. So these patients usually have 3 good, healthy tissues. Healthy kidneys with functional tissue. On ultrasound, this third kidney is going to be located lower than the typical kidneys, and it's going to look just like the other ones. It's going to have normal echogenicity, vasculature, normal function, and we would treat it as such. So we would evaluate all 3 kidneys in the same way that we would evaluate if there were 2 kidneys. Next, we have a duplicating or a duplex collecting system, and this is when our kidney actually has 2 collecting systems. So our normal kidney, if we remember from last year when we were learning about our normal renal anatomy, all of the fluid in the kidney drains through the minor calyces into the major calyces, and then they join to form that proximal ureter, and then that ureter travels all the way down and connects into the bladder, right? When we have a duplex or a duplicating collecting system, that kidney actually has 2 of those. So we're going to see pretty much double of everything, and that one kidney is going to have 2 ureters communicating and connecting that kidney to the bladder. So if we look at that duplex kidney on our diagram here, you can see our first collecting system, our second collecting system, and both of them draining into their respective ureters. So that's actually pretty common for us to see as well. And this really shouldn't be in the numerosity category of this, but this is kind of like a normal variant, a very common ultrasound finding, an extrarenal pelvis. This is when we get this chamber in that pelvis of the kidney where urine kind of collects, and it kind of just sits there. We don't want it to really sit there. We want it to leave, right? So it's a dilation of this portion of the pelvis of the kidney that gets urine kind of trapped in it, and it becomes like a urine chamber. The calyces are going to be unaffected by this, so it's not going to result in hydronephrosis. It's not going to result in a backup of fluid. It's kind of just like a little extra pocket where fluid can kind of get trapped, but it's not going to affect the actual drainage of the kidney itself. It's going to be the most common congenital renal anomaly, so that's a really big registry question that you will be asked. On ultrasound, we're going to see a cystic region right within that mid portion of the pelvis. It's going to be minding its own business. So it's not going to extend into the ureter or back up into the kidneys of the calyces. Some technologists can confuse this for hydronephrosis. Again, also can very easily mistake this for a renal cyst. But the thing that's going to tell you that it's not a renal cyst is going to be the position of it. So you are seeing it smack dab in the middle of that pelvis, whereas cysts are going to be more located in that cortical tissue itself. And hydronephrosis, we would only diagnose that if there is an extension of fluid into the ureter or a backup of fluid into the calyces. Okay, moving into abnormal renal position. We can have an ectopic kidney. So this means that it is located in a region where it shouldn't be located, typically going to be in the lower aspect of where we usually find them. So this means that the kidney failed to ascend in utero. This full ascent of the kidney should take place between 12 and 15 weeks gestation. So pretty early on in a pregnancy, we should expect to see the kidneys moving up to their respective spots. When we have an ectopic kidney in utero, it's going to be the congenital shortening of that ureter. So basically the ureter is the reason why that kidney is kind of being pulled to stay in the pelvis, because that ureter is too short and it can't allow for that kidney to move all the way up where it wants to be, right? So kind of think of like a dog on a short leash. It can't really go where it wants to go. This can actually result in infections, blockage, and failure of the kidney itself. So although it's a benign condition, these patients tend to have a lot of urologic problems. So again, if we don't see the kidney in the position where we expect to see it, we need to be looking elsewhere. On ultrasound, we are usually going to see these located in the pelvis, and they're going to have a normal sonographic appearance, so normal echogenicity, vasculature, so on and so forth. Next, we have cross-fused renal ectopia. So this is a really interesting condition, and a lot of patients sometimes will not even know that they have this. This is basically when both of the kidneys are fused together, but they're located on one side. So similar to horseshoe kidney in the sense that they're still touching each other, but this is more of a complete fusion, and they're located on only one side, whereas horseshoe kidney, they're located kind of in that midline anterior pelvis. So the kidneys are going to be fused in the pelvis before they ascend. Now horseshoe kidney, remember, they've already started to ascend, so they've already started to separate a little bit, but in cross-fused renal ectopia, they are fused at the pelvis, and then they're trying to ascend. So it's going to result in only being able to go in one direction because they're totally fused. So again, males are going to be more likely to have this than female babies, and you can have any variation of ascent and fusion of the pelvis. So if you look at some of these diagrams here, you can see that we're really only kind of seeing like one blob of kidney tissue. And depending on where they're fused, right, that's going to determine where that collecting system is going to drain out of. So pretty neat condition. And then we also have renal malrotation. So normally when we're looking at our kidneys in sag and in transverse, we want to see that hilum of the kidney in the anterior medial aspect. When we don't see the hilum facing in that normal direction, that's going to tell us that the kidney is kind of twisted a little bit. Now, it's easiest for us to confirm renal malrotation with a transverse position. Now, when we're in trans right kidney, we want to see our nice C shape, right? When we're in transverse left kidney, we want to see our nice backward C shape. Now, if we're looking in transverse right kidney, we want to see that classic C shape, but we see this, and we know our transducer is not flipped, we know our screen is not reversed, that's going to say that that is malrotated. Or if we see our transverse right kidney like this, or like this, again, telling us the same thing, but we need to be aware of our scanning skills with that. Is my transducer notch facing me, right, to the right of the patient? Is my screen reversed? Did I hit a button by accident on my screen? So these are all of the technical skills that you need to be aware of before you bring this to a radiologist or before you make note of this on your worksheet. So this bottom example, this would be a transverse right kidney, and it has that type of orientation. Okay, moving into our congenital conditions. So these are all things that patients are typically going to have genetically, or they are born with, and it's not something that really occurs over a period of time. This is something that the patients have had to deal with for a duration of their life. So the first one is going to be renal hypoplasia. This is when we have an abnormally small kidney. The renal function is going to reflectly direct that, right? Because if we have less renal functional tissue, it's not going to function as well as it should, right? So we're going to have underactive kidneys with hypoplasia. We're going to have a smaller collecting system. That means our ureters and our blood vessels are going to be much smaller and more narrow. It's usually going to be a unilateral condition, so we'll only see the left kidney really small or the right kidney really small. But some of those patients will still have hypertension. As we remember from biology and anatomy, our kidneys are a really big driving force of our overall blood pressure. So if one of them is not working as well, that can result in uncontrolled high blood pressure or hypertension. If this is a bilateral condition, we're going to see some severe clinical symptoms. The patient is going to, potentially need dialysis, kidney transplant, because we don't have enough functional kidney tissue to maintain the way that we need them to. So we're going to have some renal insufficiency. On ultrasound, we of course are going to see really small and echogenic or hyperechoic kidneys. So both of those pictures are great examples. And then here's our really tiny echogenic kidney. Next, we have unilateral multicystic dysplastic kidney, and these are a mouthful. So now we are getting into where the abdomen registry gets really hard. Renal conditions and renal pathology make up a large percentage of your abdominal registry. They are all so closely related and they all sound so similar to each other. So when you're doing your pathology charts with all of the conditions, from here moving forward in this PowerPoint, make sure you can think of something to get you to remember the similarities and then most importantly, the differences between these conditions, because by the time we get 10 slides from now, you guys are not going to remember a single word that I said, and you're going to be jumping back to each slide of this PowerPoint. So this is where a lot of students and a lot of new techs struggle in terms of studying for the abdomen registry because of the sheer amount of information that is associated with just kidney pathology. So unilateral multicystic dysplastic kidney. This is a non-hereditary, so this means that these patients do not get it from genetics, but they just happen to get it in utero. They just happen to develop this as a baby. So this is a pediatric condition. It's the most common form of a cystic disease in newborns and the most common palpable mass in newborns. Again, those are big registry keywords. These cysts in the kidney grow instead of actual functional renal tissue. So this means that instead of having functional kidney tissue, we just have cysts. So the kidney itself becomes, it just doesn't work. It doesn't do anything for us. Clinically, if we think about that, we've already kind of said if our kidney isn't working, we can't live. So if this is a bilateral presentation, it's incompatible with life. So these babies are not going to live more than a few days or weeks after birth, if they even make it to birth. If we have this unilateral, we can continue on, right? We can live with this only affecting one kidney because we have that other normal kidney to carry out the functions that we need it to. So if we have unilateral multicystic dysplastic kidney, these patients are going to have polyuria, they're going to have hypertension, they're going to be at an increased risk of infection, and it does have an increased risk of malignancy down the road for these kids as well. On ultrasound, we are going to see this kidney-shaped ball of cysts. We're not going to see any renal cortex, any renal sinus. We're going to see no renal parenchyma. We're just going to see pockets and pockets of cysts where the kidney tissue should be. So this is going to be pretty enlarged in children. And then as they grow older, as they become an adult, over time, those cysts are going to kind of degenerate and they're going to get much smaller. So when they're young and they first are kind of battling this condition, they are going to have an enlarged kidney with these really big, bulky cysts. As we get older, those cysts that have been there for 20, 30 years are going to get smaller over that period of time. So it's going to result in a smaller kind of glob of cysts. Can't even call it a kidney at that point because there's literally no kidney tissue. Our next one is medullary sponge kidney. So again, very rare, but it's going to be most common in children. So another pediatric condition. This is non-genetic based. So this is kind of just a random event that occurs in these patients. This is when we have small cysts that form either on the tubules of that functional tissue or the collecting ducts of the collecting system. So we still have functional tissue in this kidney, but now we're also battling these small cysts that are going to they're going to kind of inhibit the normal function of that tissue, right? Because we don't want something blocking our collecting system. We don't want something blocking, the tubules of that functional tissue. So we're still working in sense of the kidney function, but now we just have these other obstacles that we have to get through, all of these small cysts that are forming on those inner structures. Clinically, the patients could be asymptomatic, but they could also have hematuria, pain, hydronephrosis, right? Because if we have a cyst that's blocking our collecting ducts, that's going to cause an overall blockage as well. And then the patients are going to be at an increased risk of infections because we don't have fully functioning to capacity in the sense of the kidney. On ultrasound, we are going to see normal or small kidneys with echogenic functional tissue. This presentation means that the cysts are too small for us to see on ultrasound, so they're probably going to be measuring less than 2 millimeters, and we just can't see them. But overall, the presentation of that kidney is going to be echogenic or on the smaller side. And then the second presentation that we can see with medullary sponge kidney is going to be visualization of those small cysts in that inner aspect of the kidney in the medulla and also in the cortex with echogenic parenchyma. So our first presentation is going to be this picture down here. This is our normal to small type of kidney with echogenic parenchyma. The cysts are too small for us to see on ultrasound. So you can see kind of like we're losing the corticomedullary differentiation in this picture, right? Normally with a kidney, we like to see our hypoechoic cortex imagine that's like all colored in with our hyperechoic sinus, right? So we like to see that clear differentiation between those two compartments of the kidney. We're kind of losing that in this example here, and it almost looks like there's cortical thinning in this example, but that's really just the functional tissue. That cortical functional tissue is turning echogenic because of that presentation of the cysts on the tubules or the ducts. This top picture is showing that second presentation of medullary sponge kidney. So we can start to see some of these cysts that are forming, right? And they're small and they're kind of ranging across that cortical region. And this is something that we would most likely know from medical history. Next, we have medullary cystic disease. So you see how all of these names are starting to mesh together. First, we had unilateral multicystic dysplastic kidney. Then we had medullary sponge kidney. Now we have medullary cystic disease. We're all using like the same buzzwords, but they're all representing something different happening. So medullary cystic disease, this is a genetic condition. So this is an autosomal recessive disease. So one of your parents has to have this, and it's commonly going to affect young adults. So we're not really monitoring this in children. But as they, reach those teen years and that young adulthood, this is something that clinically will probably present itself. This is when we have small cysts that result in the fibrosis and scarring of the functional tissue and the tubules. So we never want that, right? We never want the abnormal proliferation of fibrotic tissue because that makes everything more rigid and firm and structured, and we don't want that. That's going to inhibit the normal function, and then therefore the scarring of that functional tissue as well. So that's going to result over time in that kidney not being able to work properly. So clinically, these patients are still going to have normal renal function during young adulthood, but as they get older and as they age, that kidney eventually is going to shut down in response to that fibrosis and scarring of the functional tissue. These patients can also present with anemia, salt loss, azotemia, which is when we have increased nitrogen levels in our urine, polyuria, pain, at an increased risk of infection. On ultrasound, we are going to see normal or small and echogenic kidneys with potentially small cysts. And then we can see the widening of the renal sinus as well. So I know I just said that we're going to see small kidneys potentially, and you're probably looking at this picture thinking, oh my goodness, like that's a large kidney, it's occupying the entire display of my screen. We're using a linear probe to look at that kidney. So don't be confused, right? That is a linear probe. That's the higher frequency probe. So everything's going to look slightly larger when we use a probe with a higher frequency, right? So if we were using a regular curved probe or a 5 megahertz probe, 6 megahertz probe, that kidney is not going to be looking as enlarged. But it's nice to use this high frequency probe, especially on a patient who's not overwhelmingly large, where we have nice anterior and superficial kidneys, to be able to look at that parenchymal tissue, right? We get a much better idea of what's happening in the cortex, in the medullary region, in the sinus of the kidney when we're using a higher frequency probe. So just something to be aware of with that. Next, we have our polycystic kidney diseases, and we have two different types of the main condition. So we have infantile polycystic kidney disease and we have adult polycystic kidney disease. Now, infantile is shortened to IPCKD, but it also can be known as ARCKD, and that is autosomal recessive kidney disease, cystic kidney disease. So there are a lot of different variations in terms of presentation of polycystic kidney disease. So don't be confused with the abbreviations and the different titles for them. So infantile polycystic kidney disease, this is genetic. So this is an autosomal recessive type of cystic kidney disease. Within infantile polycystic kidney disease, there are 4 types. So we break it down even further. There's perinatal, neonatal, infantile, and juvenile. Now, perinatal is when you are in utero, right? Neonatal, you are a brand newborn baby. Infantile, you're past that 3-month mark, but you're not quite a toddler, right? So, and then juvenile is going to be that young pediatric patient, so toddlers up till, pre-teen age, even through teenhood. This is a rare type of condition, but usually if one of your parents has this, they know that. And if that is a risk, they're probably going to be getting genetic testing during the pregnancy to see if the baby will have this. When we have infantile polycystic kidney disease, it's going to be the dilation of the collecting tubules, which is going to lead to renal failure. So you're probably thinking, well, like, if we're making the collecting tubules larger, wouldn't that make things easier for the kidney to function? And in a sense, when you think of it that way, it doesn't make sense. So it's a very bizarre type of potentially non-functional kidney disease. So we could get into all of the case studies and journal articles and all of the genetic components of polycystic kidney disease, both adult and infantile. But for us, you just need to know what it is and then all of the other categories and signs and symptoms of each of these. So genetically, try not to let it confuse you too much. Just make sure you understand the similarities and the differences. Clinically, these kids are going to have renal insufficiency. Their lungs are usually going to be underdeveloped, so they're going to have lung hypoplasia. They can also have it start to affect their liver, so they're going to have portal hypertension, hepatic fibrosis, and gastrointestinal bleeding. So this type of genetic condition is really playing a factor on a lot of other neighboring systems. So it's not just the kidneys that we're worried about for these kids. On ultrasound, the kidneys are going to be enlarged. They're going to be echogenic. The cysts are going to be so small that we're not going to be able to really visualize them on ultrasound. And then we're going to lose that cortical medullary differentiation like I explained on the previous slide. So we're not going to see that nice hypoechoic cortex with the echogenic sinus. It's all going to kind of be homogeneous in terms of that increased echogenicity of the kidney. So both of these pictures are really great. Here is our very enlarged, kind of homogeneous kidney. And then a little bit slightly more normal looking, but still abnormal looking, that bottom picture there. Next, we have adult polycystic kidney disease. So this is also genetic, but it's autosomal dominant. I apologize. I think I've been saying that the autosomal recessive are from your parents, but I believe that means it has to come from potentially a grandparent or a parent, whereas autosomal dominant has to come from just a parent. I need to brush up on my genetic information here. So I will clarify that, and I will post that in this module as well. So adult polycystic kidney disease, this is the autosomal dominant version. This is going to be a bilateral disease where we get these multiple cysts that form in the cortex and the medullary region. So this makes a little bit more sense in terms of what we're naming it, whereas the infantile polycystic kidney disease was more about the dilation of the collecting tubules. This is us actually forming a numerous amount of cysts. Clinically, this is going to affect patients well into adulthood, 40 to 50-year-olds, but usually by the time they turn 60, they are going to have end-stage renal disease. So these patients are going on dialysis. They're hopeful to get a kidney transplant. They're going to have hypertension, renal failure, all of the other symptoms that are associated with non-functioning kidneys, pain, fever, chills. hematuria, uremia. They could potentially have a palpable mass depending on how big these cysts get. And they can also have polycythemia as well, so kind of interesting little clinical sign. Ultrasound, we're going to see enlarged kidneys with tons and tons of cysts, varying size. We're going to be losing our normal kidney shape. Our cysts, depending on how old they are, can have an atypical appearance depending on if they're degenerating, if they're infected, if there's a stone nearby, if one of the cysts is bleeding out or it's a hemorrhagic cyst. So we want to make sure that we are at least evaluating all of the cysts. We're not measuring all of the cysts. So I've seen a lot of new techs scanning polycystic kidney disease in an adult, and they are in there for, close to 2 hours, and I've checked on them and they're measuring all of the cysts because they've never scanned a polycystic kidney before. We are not doing that. We are usually, depending on your site protocol, measuring the largest cyst, and then we are also measuring any cyst that is not simple. So any cyst that has debris, any cyst that looks abnormal in shape, any cyst that looks complex. Those are the cysts that we're measuring. So we are not measuring every single cyst in a polycystic kidney disease patient. Just want to make that clear. Moving into our inflammatory conditions. So now we're talking about infection, inflammation, viral, bacterial. Our first one is going to be acute pyelonephritis. So itis is always going to tell us that there's inflammation happening. Neph is always talking about a kidney. And pyelo usually is talking about some type of infection. So acute pyelonephritis, this is going to be the acute inflammation of that renal tissue. Clinically, they're going to have flank pain and fever. On ultrasound, depending on how long they've had this for, if it's brand new, early in the diagnosis, it could have normal kidney appearance. And then sometimes we can see in either a focal portion of the kidney or in the entire kidney itself, we could see an increase in size. We could see areas of increased or decreased echogenicity. And we're going to see absence of blood flow or perfusion when we put on our color Doppler. So kind of weird when we think about there being an inflammatory process and not seeing color in an area, right? Because usually that means that the tissue is inflamed. It's trying to work overtime. It's sending all of its, blood supply and all of those antibodies and all of those lymphocytes and white blood cells into that region of inflammation or infection to try to fight it off. So we usually get this overwhelming amount of blood flow to an infected or an inflamed area. But for acute pyelonephritis, we're not. So we're not seeing that perfusion or that blood flow into that area. So it's kind of a bizarre in its behavior, at least with its appearance on ultrasound. We're going to see a loss of cortical medullary differentiation. We're going to see compression of the renal sinus, depending on how much of that kidney is being affected by this inflammation. And we could see it unilaterally or bilaterally. Typically, if we have pyelonephritis, it's an inflammation of the urinary system. So a lot of viral infections or bacterial infections come from the bladder. So usually I would expect to see these conditions be bilateral. Next, we have emphysematous pyelonephritis. So that's quite a mouthful. Anytime we see that emphysema, we'll actually kind of see this when we get into leg pathology as well. Anytime we see emphysema or emphysematous, we're talking about gas. We're talking about air. We don't want to see air anywhere besides in the bowel, right, or in the stomach. We don't want to see air anywhere in the body besides in the lungs and in the gastrointestinal tract. So if we're seeing air in the kidneys, we need to find out what's causing it and why. Usually the culprit of causing air within an organ that shouldn't have air within that organ is some type of viral or bacterial infection. So we get an infection in the kidney which is going to result in inflammation because we have pyelonephritis, but that infection is going to create gas in that region. So if you've ever done like any type of experiment in biology, maybe you even did this in elementary school where you do like a petri dish or you do a piece of bread, right, to see how moldy bread gets, how fast it gets. If you put it in like a bag or you put it in an incubator, it forms gas, right? So it's going to expand that environment. It's going to get warm. It's going to have like moisture to it, right? And we don't want that in our kidney. We don't want gas formation in our kidney. So whatever these infectious cells are, they're causing it to produce gas as that infection proliferates in that organ. So clinically, these patients are going to have fever, pain, dehydration, acidosis, electrolyte imbalance. It's really going to affect that primitive function of the kidney. On ultrasound, we are going to see that echogenic gas actually within the tissue of the kidney and the collecting system. So this picture here, our overall gain is a little bit too bright, but if we, take that into consideration, look at all of this gas. And this isn't just like nearby gas from the bowel. This is the border of the kidney. And that gas is coming right from that pelvis. And even all that gas shadowing that we would expect to see. So pretty nasty. Anytime we get gas formation in an organ that shouldn't have it, it can be a life-threatening condition. That means that infection is proliferating very quickly. Next, we have chronic pyelonephritis. So this is when we have patients who just have these chronic UTIs. They have these ongoing episodes of inflammation to their kidney, kind of like pancreatitis, right? Over a period of time, like our organ has been dealing and trying to fight with this inflammation and this infection for so long that eventually it's just going to kind of give up. So clinically, the patient at that point is going to be asymptomatic and they're going to have renal failure. On ultrasound, we are usually going to see this bilaterally, especially if we're at the point of chronic pyelonephritis. We're usually not going to be sparing a kidney if we're just constantly dealing with this inflammation or these recurring UTIs that are causing it. And then we're going to see areas of cortical thickening, and they're going to start to become more echogenic. Cortical thinning, not thickening. I think I just said thickening. But you can see here really thin cortex, right? Pretty much throughout the entire kidney. It's still kind of normal here, but all of this cortex is not. It's all thin. Next, we have acute tubular necrosis. So this is when we have the damage or death of the renal tubules. This is going to always be a bilateral condition, so we need to be aware of this in our patients. These patients are usually going to be going for dialysis. Clinically, we are going to see acute kidney injury. That is a test that is run pretty much in every emergency room when a patient comes in for kidney stones or flank pain. We are also going to see uremia, electrolyte imbalance, and oliguria. Ultrasound, we are going to see potentially a normal-looking kidney, but we're usually going to see bilateral enlargement and increased parenchymal echogenicity. So this top picture here, this is most likely what we're going to be seeing. Kind of still looks like a normal kidney, right? But maybe it's a little bit enlarged, and that cortex is starting to look kind of fluffy. Right? It's starting to look a little bit more hyperechoic. Now this picture on the bottom, this is actually a contrast image of the kidney, so pretty neat. We use contrast a lot to evaluate the vasculature of an organ. So when we inject contrast into the patient, it goes to that respective organ and it travels all throughout the vessels of that organ. So we can kind of see which areas are getting blood supply and which areas are not. And that makes it much more easy for us to identify areas that are not functioning properly or areas that may have like a discrete tumor in them. We use contrast a lot for liver imaging, but we also are using it for renal imaging as well. Next, we have pyonephrosis. So this is when we have pus within the collecting system. So gross. Clinically, patient will have fever, flank pain. On ultrasound, it's going to show hydronephrosis, but it's not going to be nice and simple urine or fluid. It's going to be infected pus. We are going to be able to see mobile echogenic debris within that hydronephrosis, and that's exactly what we are looking at here. So all of this echogenic fluid, this is all thick pus that's trying to settle in that collecting system. This is what normal hydronephrosis should look like. So if we're seeing that echogenicity, we need to question something further. Next, we have acute glomerulonephritis, another mouthful here. This is when we have the accumulation of inflammatory elements. So we kind of, similar to pyelonephritis, we're kind of in a constant inflammatory state, right? Our kidney is kind of still persistently fighting off the cause of this inflammation. But this is a little bit more specific in terms of it's the actual inflammation of that functional cell, the glomeruli, and it's going to result in death of that. So we're going to have death of the functional cells of the kidney. So clinically, these patients will have hematuria, hypertension, azotemia. On ultrasound, we are going to see normal or enlarged kidneys, potentially a normal medullary region, and we could see variable echogenicity of the cortex. So we could see it become hyperechoic or echogenic. Now, as we move through all of these, you're probably thinking, what difference is this picture from this picture, from potentially acute pyelonephritis, right? That top picture. And the answer to that is there really isn't any. This goes hand in hand with clinical presentation, laboratory values, right? These images support those diagnoses. These images are not the sole driving factor of these diagnoses. So keep that in the back of your mind, especially when you're studying, that I'm not going to give you a picture of a kidney that looks like this with no information, no clinical history, no laboratory values, and say to you, tell me the difference between acute glomerulonephritis. Like, I'm not going to give you a multiple choice answer or question with this picture, and your options are acute glomerulonephritis, acute pyelonephritis, tubular necrosis. I'm not going to do that. You're going to have other context clues to help you reach that answer. Next, we have candidiasis. So this is a fungal infection that can really affect pretty much any organ, but the urinary system and also the hepatic system, kind of that upper gastrointestinal system, can be prone to this fungal infection. Usually normal healthy patients can prevent this infection from causing havoc in their body. They can kind of fight it off without the patient ever knowing, but immunocompromised patients are going to be more susceptible to this. Clinically, we are just going to see the worsening and that progression of symptoms in patients who are already sick. So if you're an immunocompromised patient, say you're a cancer patient and then you get candidiasis, well, your cancer symptoms are going to just be exacerbated. Or say you are an HIV/AIDS patient and you get candidiasis, the symptoms that you're already having from your autoimmune disease is going to just be worsened. So there aren't specific symptoms that are associated just from the candidiasis itself. On ultrasound, we're going to see multiple focal abscesses of varying echogenicity throughout the renal tissue, and we could see some focal echogenic masses within the collecting system itself. So here we just have this focal guy hanging out in that kidney. Next, we have schistosmiasis. This word is not my friend. We've already talked about this with our biliary pathology, right? This is a parasitic infection. So again, it's not just associated with one organ or one type of organ system. It can really kind of settle anywhere in the body. Clinically, these patients will have hematuria. On ultrasound, the kidneys could appear normal, but we could also see some blockages resulting in hydro. We could see a bladder wall granuloma, which you will learn about in the urinary PowerPoint. We could see some bladder wall thickening and some calcifications. So again, this parasitic infection is usually going to originate into the bladder and then therefore travel up to the kidneys themselves. Next, we have an abscess, pretty self-explanatory. We know all about how abscesses behave in every organ, so just be aware that the kidneys are not immune to an abscess. Moving into our benign masses, probably thinking like, oh my gosh, how many more do we possibly have? Well, we have quite a few more. We're about halfway through. So very easy. We're not going to spend too much time on this. A cortical cyst. These are renal cysts. These are different than that extra renal pelvis that I said, right? These are going to originate in that cortical tissue. We can have some complications from these. They can get super big. They can get infected. They can bleed. So they can be problematic for the patient, but they're benign. They're not really anything to worry about. And we also want to make sure that with our cysts, that this is why we are sweeping all the way superior, all the way inferior, all the way lateral, all the way medial, because we can get what are called those exophytic cysts. And that means they hang off of just that little border of that kidney tissue. So sometimes you can totally miss it because it's just barely hanging on by like a little piece of tissue. So we want to make sure we're fully evaluating for exophytic cysts. Next, we have a parapelvic cyst. So again, this can very easily be confused with an extrarenal pelvis, but an extrarenal pelvis is going to be sitting near that hilum in that mid portion of the pelvis. Parapelvic cysts can be sitting anywhere in the pelvis themselves. So these are very similar to regular cysts of the kidney, but they are not located in the cortex. Renal cysts are located in the cortex. Parapelvic cysts are located in the pelvis. Extrarenal pelvis is not a cyst, but it is located in that pelvis and sometimes can look like a cyst. So make sure you understand the difference between all three cystic-like benign findings. Next, we have acquired cystic kidney disease. You're like, I thought we were done with diseases. Nope. This is when we have patients undergoing dialysis, and because of that dialysis treatment, they start to develop cysts. And that can either be in their regular kidney that they have, or it can be in their transplanted kidney if they do have an extra kidney in there. Fun note, when you get a kidney transplant, say your left kidney stops working, you get a kidney transplant, they do not remove your left kidney. They keep that non-functioning kidney in there. So if you are continuing to go through dialysis, even after you've had a kidney transplant, you can get these cysts that occur in the old kidney and in the new kidney because of that really extreme treatment that you're going through. Dialysis is tough. It's a rough thing to have to go through. If you haven't known anyone who's had to go through dialysis, it is truly, truly exhausting for these patients, and it's really unfortunate. Clinically, the patient will be asymptomatic, but they will be at an increased risk of tumor development. I don't think that that's necessarily from the cysts themselves. I think that's more from the dialysis process. On ultrasound, we will just see multiple cystic areas of varying size. It's going to, it's not going to favor one kidney over the other. Like we said, it can occur in any and all kidneys. And we are going to see cortical thinning. That could be in relationship to the reason why the patient's on dialysis, right? Chances are they're not going to have these normal, beautiful looking kidneys if they're on dialysis. So just keep all of that in mind when you're working with these patients. Next, we have an angiomyolipoma. These are so cute. I love finding these. These are also known as renal hamartomas. They are made up of angio, myo, and lipoma, hence the word. Fat, blood vessels, and smooth muscle cells. So fat is the lipoma, blood vessels is the angio, and smooth muscle cells is the myo. So it tells you what it's made up of in the name. Females are going to be more likely to have these than males. they are going to be asymptomatic, but sometimes they can get kind of big, and that can result in them bleeding, and we can have some problems from that as well. But usually we're going to see these nice and small. We're not going to see them causing too much of an issue, but if they do, patient could have flank pain, they could have blood in their urine from that hemorrhage, they could potentially have hypertension if they're really affecting the overall function of that kidney, but that's not as likely. On ultrasound, we're going to see a hyperechoic mass in that kidney tissue. They could be variable in size and echogenicity if they are bleeding. So that bottom picture, that's what an AML is going to look like. An angiomyolipoma, small, minding its business, kind of looks like a hemangioma in the liver, right? But then that top picture, we see that central degeneration portion. That means that could be bleeding, right? We could have some hemorrhage occurring in that larger AML in that top picture. Next, we have an adenoma. Again, we know all about these. They can occur anywhere, anywhere that has functional tissue. They kind of mind their own business, but any solid tumor other than an AML, we're probably going to be further evaluating. So next we have an oncocytoma. This is when we actually have these benign tumors that are made up of oncocytes and epithelial cells. Again, you wouldn't know that from just scanning these patients, but these are pretty big and they're pretty scary looking, even though they are technically benign. They can be precancerous. So anytime we see a solid mass, like I just said, we're going to further evaluate it. And anytime we see a solid mass this big, we're taking it out, right? Whether it was pre-malignant or not, we're taking that sucker out. So with oncocytomas, most likely going to occur in older men. They could be asymptomatic, right? It's benign. It's probably going to mind its own business quite a bit. On ultrasound, we're going to see a solid tumor, variable size, variable echogenicity. And like we said, it's hard for us to differentiate that from a really big cancer that's growing. So we're doing a further evaluation on anything that looks like this on ultrasound. Next, we have mesoblastic nephroma. So this sounds like it would be cancerous, but it's not. It is a benign version of a pediatric cancer that we'll talk about in a second. So it's the benign version of a nephroblastoma, which we kind of touched upon a little bit with our adrenal PowerPoint. This is going to affect children, so they're going to have a really palpable flank mass because children are small, right? And these masses get really big, so they're going to be able to feel that on their flanks, and they could affect the function, resulting in hypertension in a kid. We know we don't want to see hypertension in a kid, so if a doctor happens to notice that, they're going to question it and do some type of imaging or testing on that patient. On ultrasound, variable echogenicity, depending on how big it is, depending on how long this kid has had it, we could see some calcifications, we could see it starting to degenerate. So really, we're not playing around with this either, even though it is a benign condition. We're not just leaving it alone. We're taking that out, and we're doing something preventative. Moving into our malignant kidney pathologies. First one, RCC, renal cell carcinoma. This is like, I'm not a huge Harry Potter fan, but I know when he uses like that invisibility cloak, like that's what these do. Like they blend right in with the tissue. They are so easy to miss on ultrasound. These pictures are very obvious and blatant pictures of RCC. When you're scanning a patient and you have RCC, they're not this obvious. These are also known as hyponephromas, which can be confusing because when we hear an OMA, we're not really thinking malignant, right? We're usually thinking benign for the most part, but in the renal world, hypernephroma is not good. It is renal cell carcinoma. Same thing on our next slide. We're going to talk about a nephroblastoma. It ends in an oma, right? Not a carcinoma, but it ends in an oma. So we usually think like, oh, adenoma, usually going to be fine, but it's not. So don't be confused with that word composition when you're studying for this. This is when we get cancerous cells in that tubular region of the renal parenchyma. So it really starts on a very primitive level. This is a primary type of cancer. This is not a cancer that starts somewhere else and then spreads to the kidney. This is originating in that cellular aspect of that kidney parenchyma. Clinically, the patients are going to have pain, blood in their urine, possible palpable mass. depending on how bad it is. These are usually going to be pretty small. Like, they don't get super, super big. So if we have a palpable mass and it's an RCC, chances are it's really not good and it's progressed far along. On ultrasound, we're going to see a solid mass with variable echogenicity. We're going to see it partially exophytic, so we're going to see it wanting to leave that kidney. We're going to see some calcifications. It's going to be hypervascular, right? If it's got a big blood supply to it, chances are it's trying to grow and it's trying to spread. We're also going to see a possible echogenic mass in the renal vein, and it could spread all the way to the IVC and then the contralateral kidney. So that's how it's going to spread, is through that vascular supply to the, or from the kidney rather. So this top picture, if we were looking at this and we saw a dromedary hump, we wouldn't want to confuse the two, right? We need to say to ourselves, okay, this is occurring in the lower pole, and I actually see a border with that cortex. So I know that that's a real finding and not just a dromedary hump. Same thing with this one down here. It's not an extrarenal pelvis, right? That's not an extrarenal pelvis. This whole thing is a tumor forming in that cortex. Next, we have nephroblastoma. This is also known as a Wilms tumor. This is that malignant pediatric condition. This is really unfortunate, but it is very, very common in pediatric kids. So clinically, they're going to have fever, blood in their urine, flank mass, hypertension. On ultrasound, we're going to see these really large variable masses. They're echogenic. They're cystic. They could have calcifications. They could also have this association with horseshoe kidney. We said horseshoe kidney is going to be at an increased risk for some things to happen down the line. So nephroblastoma is going to be one of them. So we want to remember that the benign counterpart of a nephroblastoma is a mesoblastic nephroma. So make that connection when you're studying. And of course, metastatic disease. Cancer can spread anywhere in the body. So anywhere from the body to the kidney, we're usually going to have symptoms of that primary cancer. And on ultrasound, if it does spread to the kidney, it's very variable. Usually everywhere else in the body is going to be that bullseye lesion, right? The hypoechoic with the hyperechoic center. So we can still see that in the kidney, but sometimes we can get these like really echogenic masses. We can get a really hypoechoic mass. We can have one site of METs to the kidney. We can have multiple sites of METs to the kidney. So it can really be more variable in the kidney than it usually is elsewhere. Now this top picture, I have to be honest, I don't know if that would draw my attention while I'm scanning. And that's scary, right? Is that even a trained eye can sometimes miss that. So you need to be aware of your patient history. You need to be aware of their symptoms. So if we're scanning a right upper quadrant and the patient has known hepatocellular carcinoma, we don't want to just mainly focus on that liver. We want to look for METs elsewhere. And that is something that we would want to question in that top picture. Okay. Light at the end of the tunnel. Moving on to our kidney stones here. So before we actually talk about our kidney stones, I feel like I sound like a podcast when they before they get into their topics, they do like an ad for HelloFresh. First is a hydronephrosis. We have to talk about this. This is when we have that dilation of that renal pelvis and the calyces of that collecting system due to an obstruction that doesn't allow the urine to fully exit the kidney. We've talked about it throughout this PowerPoint. I've talked about it in lab. We talked about it a little bit last semester, but we need to just go back to it before we actually talk about our kidney stones. So the causes of hydronephrosis, there are three main causes. The main one that we think of is stones, right? That's going to be the most common one. That's an intrinsic cause, meaning that there is a stone originating in that kidney, or there's a tumor along the way of that kidney or ureter or bladder that's causing this obstruction and this backup of urine into the kidney. Extrinsic causes are going to be if there's trauma, right? You get into a car accident, you smush your kidney, you smush your ureter, and it doesn't allow urine to travel through, or an infection. Those are outside causes coming in to block it. Congenital, meaning you have an anatomic variant, you have an ectopic kidney, you have a horseshoe kidney, you have malrotation, whatever anatomic variant it may be, usually dromedary hump and column of Bertin, they're usually not going to result in hydronephrosis, but any of those other anatomic variants can. On ultrasound, we are going to see that dilation of the pelvis and the kidney. So we're going to see mild to severe fluid-filled pelvocalyectasis. That's what we call it, the dilation of the pelvis and the calyces. We're going to see hydroureter. We're going to see cortical thinning depending on how long the patient has had hydronephrosis for. We're going to see non-visualization of that sided jet in the bladder. And then we are going to see an increased resistive index. So that is known as our RI. When we Doppler the kidney, meaning we put color on, we Doppler one of those arteries in the cortex, so whether it be the arcuate or the interlobular artery, we get a waveform, we get an arterial waveform. When we do a resistive index and we have our arterial waveform, we are measuring our peak systolic velocity and our end diastolic velocity. Those two measurements are going to calculate a ratio. That is going to give us our resistive index. If that ratio is too high, we know that something's wrong and that's affecting the overall function of the kidney. Okay, so here we have a grading system. For me, you do not need to know the Granger system, but for your registry, you do need to know what is grade 1, what is grade 2, grade 3, grade 4, and what would that look like on ultrasound. So we just need to know that any version of this is not normal. This right here, most radiologists would probably still call that the normal range, but anything from here, worse, really needs to be further evaluated. So here we have those four different types of grading systems. This is going to be our classic appearance of hydro, right? There's, hydroureter here, there's pelvicalyectasis, but we could assume that there's some type of blockage here, right? Now this picture underneath it, okay, well, yeah, we have hydro in the kidney, but whoa, that is some hydroureter, right? I'm assuming this is bladder here, so there's probably some blockage that's happening here. Now, this picture, we are all the way at the bladder, and I would assume that there would be a blockage here right before it empties into the bladder because we're still seeing it dilated that distally. And then, look at how nasty that one is, right? That's really severe hydronephrosis up there. We can even see some echogenic debris in it, so maybe there's something else going on in terms of the cause. And this was even from this annotation, this was even after they had the patient urinate and void. This also shows that cortical thinning that can happen due to severe hydronephrosis. So anytime you see a picture that looks like this, where it's kind of on the mild side, it's there, you want to evaluate it, have your patient go to the bathroom. First of all, check their bladder. Is their bladder overwhelmingly distended? If it is, have them go to the bathroom, empty their bladder, have them come back. When you go to check that kidney again, is that still there? Is that hydro still persistent? That is truly real. If your patient fully went to the bathroom, their bladder was super, super full, they were ready to burst, they went to the bathroom, their bladder is empty now, you go up and you check that kidney and there's no hydro there, that's fine. That's normal. That was just too much urine in the system for that patient to continue to keep holding. But if your patient goes to the bathroom, their bladder is empty, this is still there, we need to confirm that that's true hydronephrosis. And then all three of these other examples, I mean, that's not going to just happen from a full bladder. That's pretty severe. So that is going to be pretty cut and dry, severe hydronephrosis. Moving into our calcifications, our stones. So kidney stone, kidney calculi. This is that focal concentration of, components of calcium, struvite, uric acid, cysteine, any kind of combination of those elements. These can occur in the renal parenchyma or the collecting system. Males are more likely to have this than females. Clinically, the patient is going to be asymptomatic, but I don't know of too many patients who don't complain of pain with a kidney stone. So for the most part, patients are going to have acute pain and blood in their urine. Usually pain is associated with movement of the stone. So if your stone stays put, usually the patient does not really have any pain. They may have a dull ache here and there, but usually once that stone starts to move, that's when that excruciating pain happens. And because there's so much movement of the collecting system in the kidney, chances are that stone is going to move. We don't see too many stones that really stay put for years and years and years. Usually the kidney is going to try to flush them out. On ultrasound, we're going to see very hyperechoic focus with shadowing, twinkle artifact when we put color on. Depending on the size and location of that stone, we can see some obstructive hydronephrosis. We can see them moving around and dancing in the bladder, which is kind of neat. And then we could see echogenic focus in the dilated distal ureter, depending on if it's traveled from the kidney and now it's trying to make its way into the bladder. One of the things that you need to be aware of in terms of renal stones is a staghorn calculus. Most kidney stones, patients are able to pass, or they're able to blast with a laser, which breaks up a large stone into smaller pieces so that the smaller pieces can pass. But a staghorn calculus is a massive, massive stone that occupies the entire collecting system. So our two pictures up here, beautiful, nice stone, right? Beautiful twinkle artifact. Staghorn calculus is that entire thing. So you're not passing that stone. Surgically, they will go in and they will remove that stone. They're not lasering that stone. You're not passing that stone. So they're pretty neat. And even if you Google it, it's a really cool thing to see the actual shape of a staghorn calculus and how it does represent like filling the entire collecting system. Next, we have nephrocalcinosis. So this is when a patient has increased calcium levels in their blood or their urine, and those calcium cells get deposited in the kidney parenchyma. So it's not really like multiple stones in the kidney. It's kind of just these pockets of calcium. It's really common in infants, and it usually occurs bilaterally throughout the entire kidney themselves. So when you see this top picture, you're not going, oh my gosh, like these are all stones, I have to measure all of these. They're not technically stones, right? You don't see them shadowing, you don't see them giving you twinkle artifact, you don't see obstructed hydronephrosis. This is nephrocalcinosis. This is that overwhelming amount of calcium in that patient's system. It has nowhere else to go but gets stuck in those kidneys. So we just want to treat it as that. Same thing with this bottom picture. You can see all of those echogenic little foci. Again, these are not individual stones, even though they're made up of calcium. But if you wanted in this type of presentation, you could measure this bundle of calcium deposits and this bundle of calcium deposits and this bundle of calcium deposits, as long as you are aware that that is not representing one larger stone. And you're communicating that with your radiologist. Next, we can have cortical stones. So these radiologists will disagree on. You want to be aware of your site's protocol and your site's practice, but basically we can get diffuse or focal calcium deposits in the renal cortex. This is not like nephrocalcinosis. Nephrocalcinosis is happening bilaterally throughout the entire kidney itself. This is when we get a little bit of calcium got stuck here, a little bit of calcium got stuck there, and it kind of forms this stone-like appearance, but it's not super, super hyperechoic like a true stone is. It does not have a lot of shadowing behind it. It's not really going to produce a twinkle artifact. It's minding its own business in the cortex. It's not blocking anything. So yes, you want to show it. Yes, you want to measure it. But you may see in the report that the radiologist might not call that a stone. They might just call that a focal calcium deposit. So just be aware that these cortical calculi can really be variable depending on the place that you're at. Next, we have some additional conditions. So just finishing up here with some kind of vascular conditions and kind of other things that we can see with the kidneys that don't really fit into anywhere else. Here we have our acute kidney injury to our chronic renal failure. So AKI is a big indication on a lot of renal exams that we get, same as a CRF, renal failure. This is when we have the impairment of the renal function. So for whatever reason it may be, that kidney cannot function properly. We're not giving it a specific reason or cause, right? So it's the inability for that kidney to maintain the normal processes that it needs. So this is kind of like a blanket statement that we give on a patient that has a kidney that's not functioning properly. We can have a pre-renal type of acute kidney injury, a renal, and a post-renal type. That's mainly talking about the causes. But again, if we're giving somebody the diagnosis of AKI, we're kind of being vague here, right? Same thing with chronic renal failure. Well, yeah, the kidney's not working, but like, why is it not working? So we're being vague in that diagnosis. Clinically, the patient is going to have a wide variety of symptoms with both acute kidney injury and chronic renal failure. On ultrasound, we're going to see that progression of that normal kidney appearance as it starts to decrease in size, our cortex starts to thin, it starts to become more hyperechoic. So really the start of the renal failure is the acute kidney injury. So this is kind of like the prerequisite to chronic renal failure. AKI, our kidneys starting to not function properly. And then as that progresses and it keeps not functioning, that's when we fall into the ballpark of chronic renal failure, kind of like fatty liver and cirrhosis, right? So we're going to have a wide variety of ultrasound appearances, but these patients we're probably going to monitor. They'll probably come in once a year, and we'll be able to see that progression of that kidney starting to deteriorate on ultrasound. And we also have trauma. So kidneys are very sensitive to any type of blunt force trauma, any car accident, anyone hitting you across your back. I remember being a young kid, and that was taken very, very seriously in school, in extracurriculars. I mean, if anyone saw, like, boys used to, joke around and hit their friends in the back and all of that. And I remember that being taken very, very seriously. And that's for this reason. Kidneys are very sensitive to that. They don't have anything to protect them, right? They're a retroperitoneal structure. So we don't have the peritoneum to soften the blow in episodes of trauma. It's going to potentially result in rupture of the kidney and the capsule, subcapsular hematoma. We can see a laceration of the tissue. We can get a urinoma because urine has now escaped the urinary system because of that trauma and that potential rupture. Clinically, the patient's going to have pain, blood in their urine, oliguria, hypertension, decreased hematocrit levels. On ultrasound, we're going to see free fluid within the abdomen, so we want to be checking those abdominal spaces that we learned about. We want to be looking for any type of hematoma that's forming. And next we have infarction. So just like the spleen, we can get these little focal areas of tissue death due to lack of blood supply, usually the occlusion of that artery feeding that region. Clinically asymptomatic or localized pain. On ultrasound, we are going to see, depending on if it's old or new infarction, if it's a new infarction, new tissue death, that tissue is going to be hypoechoic. If it's old tissue death, it's been dead for a while, it's going to be hyperechoic, small in size. You could see some areas of scarring. So this would be a chronic infarction right here. Hyperechoic, small in size, starting to retract a little bit. Next, we have renal artery stenosis. We will learn about this more in our vascular class in the fall, but this is when we have a narrowing of that renal artery lumen, usually caused by plaque or, as we just learned, atherosclerosis. Clinically, this will present in uncontrolled hypertension. So if you see an order for renal artery stenosis, the main Indication will be hypertension. On ultrasound, the kidneys itself will have a potentially normal appearance, or slightly small in size and increased echogenicity, so they'll become hyperechoic. So if you think about it, they're not getting the amount of blood supply that they need, so that's going to ultimately result in the kidney not working as well as it should. And we'll learn more about that type of exam in the fall. Same thing here, renal artery occlusion. So now, we don't have a narrowing of that renal artery, but now we have the total blockage of that renal artery. So this is really going to result in tissue death of that kidney. On ultrasound, we're going to see a decrease in that kidney size right after the initial phase. And in that initial phase, we are going to see it really large. So think about like a torsed testicle. Right, we cut off that blood supply, it's occluded, there's no blood supply getting to that testicle. At first, it gets really, really big. Like the testicle swells because it's like, help me, like I need blood supply, like I need something here. And then it's not getting it, so it's like, all right, well, I just got to give up, right? And then it gets smaller. So the initial acute phase of an artery occlusion is going to result in an enlarged kidney, and then once it realizes it's not getting rescued, nothing's coming to help it, that's when it starts to decrease in size. And of course, any type of occlusion, we are not going to see any blood flow to that organ. And lastly, congratulations, you officially made it through, is our renal vein thrombosis. So we have a blood clot in that renal vein that is draining that kidney. Clinically, the patient could be asymptomatic, but they could have some flank pain. We want to make sure we follow that renal vein to the IVC and that we follow that IVC back up to the heart as much as we can. On ultrasound, we're going to, again, see an increase of that kidney size during that acute phase, and then after that acute phase, it's going to be a little bit smaller. We're going to have variable echogenicity, and of course, we're going to see absence of blood flow in that vein. So congratulations, really long PowerPoint. Few things I do need to post for you guys on here as well. I am going to follow up on the genetic autosomal recessive versus dominant, like who that comes from, if that's your parents or your grandparents. And then the schistosomatiasis slide as well. So I will be posting more information in the module, so please make sure you check that, and then please make sure you are doing your self-guided renal urinary PowerPoint as well.